So for today, my talk will be about the controversy of antipsychotics in neurotoxicity, and we'll talk about the concept of what we call the first do no harm. Okay, so the objectives for today's lecture is going to applying the non-maleficence in modern medicine, how antipsychotics affect brain structure, and we're gonna question are antipsychotics are neurotoxic or not. So the principle that we work in medicine is called primum non nocere, is a Latin maxim that means first do no harm. And also from it it's derived the concept non-maleficence. It's derived from this maximum, and it's one of the principal precepts of medical ethics. It's actually not in the Hippocratic oath, but derived from the sentence, I will keep them from harm and injustice. So the phrase primum non nocere, or the first do no harm, is not mentioned in the Hippocratic oath, Hippocratic oath, but it's derived from the sentence, I will keep them from harm and injustice. So arguing with this concept sometimes is giving an existing problem, an illness, a body problem. It's maybe better not to do something, or even to do nothing, than the risk of causing more harm than good. So sometimes doing nothing is better than doing something that can be harmful. Okay. So in any intervention you're going to do, you have to consider what's the harm I'm going to do to my patient. So in an article published in the BMJ in 2002 and under the title Why the Hippocratic Ideals Are Dead, Dr. Laufer argues that in contemporary medicine, with all this new investigation, all this array of clinical investigations, some harm is almost always done. So for example, if you want to do a chest x-ray to investigate a chest infection, you're exposing the patient to radiation. So there is some harm. You're doing a CT scan, you're exposing the patient to radiation, which maybe have a long-term consequences. So you have always to think about, is it necessary to do an X-ray before I go ahead and do an X-ray? Is it necessary to do the CT scan before I go do a CT scan? It's necessary because there is some harm always in this kind of interventions. So sometimes for certain diseases, we don't need to intervene. Like for flu, for example, now we don't give, sometimes the recommendation is just take some rest, take some vitamin C, instead of giving patient antibiotic or although antiviral are available, we don't prescribe antiviral from the first visit for flu. The natural disease of the illness tell us that eventually it's going to go away. So for some diseases, they might heal by themselves. Sometimes surgeons, they don't close the wound. They keep it open and they keep it for the natural healing. Okay. Sometimes in certain intervention, harm may not immediately apparent. Like for example, CT, there is some like exposure to CT on the long run might expose you to some kind of cancer like leukemia, this kind of consequence of CT. So you might not see it immediately, but there is a long-term effect of these investigations. So Dr. Laufer argues that in medicine we are aware of many instances in which improving target symptoms worsens other symptoms. Like for example, if you have a patient who have complaining of back pain and you want to prescribe him on NSAIDs, like a non-steroidal anti-inflammatory medication, you are putting him at risk of GI bleeding. Okay? Hormone replacement therapy for postmenopausal symptoms increase the risk of clots, or even contraceptive medication can increase the risk of blood clots. So there is always some kind of harm behind any intervention we might recommend or do. So he argues that the Hippocratic ethics do not tally anymore with the realities of modern society, so we cannot apply the concept of first do no harm in contemporary medicine. Okay? So the society and doctor must get to grips with the ethical consequences of the medical revolution. So we cannot prevent harm to our patient. Or is it? Or can we prevent harm? So Dr. Rodi replied to this article saying that whilst many modern investigation and interventions do have some potential adverse effect and complication, it's the balance of potential benefit and potential harm. So that's what you put in consideration. Are the benefits outweighing the risks? So this is where we can reduce the harm. So if the overall benefits outweigh the potential complication, the Hippocratic ideal are still respected. Okay. So he concludes that harm, often in the form of death itself, can also be incurred by failing to intervene. So it's not just the side effect of medication, side effect of the intervention. What we are doing is we're trying to delay or prevent death at certain situations. So even if harm is there, the major benefit is preventing death. So we need to get a valid consent from the patient, and the patient has to understand in the broad terms that he doesn't have to know all the exact details of the side effect, because some side effect, if the patient hears about all the side effects of certain medication, he may not accept to take the medication. So if the patient aware of this, of the risks and the benefit from medication, and he accepts the medication, then we still kind of we are sticking to the Hippocratic oath. Okay. So he concludes that in an age when technological advancement has inevitably amplified the potential risk to patients and has increased longevity, or sometimes at the expense of quality of life, we believe that the Hippocratic ideals are more important than ever and remain the cornerstones of ethics in modern medicine. Okay. So that's the start of my argument about the side effect of antipsychotics. So going now to focusing on the antipsychotic side effect. First, we need to know what our antipsychotics are used for at this stage. Okay, so we use it for psychosis. We use them for control of agitation, whether psychotic or not. We use it for bipolar, for mania. We use them as a augmentation for depression, for anxiety, for obsessive compulsive disorder, delirium, behavioral disturbance, insomnia, etc., etc. So we use antipsychotics in many contexts. It's not just limited to the use of antipsychosis. They now have a broad use for antipsychotics. So what harm can antipsychotics do? So we know the side effect of antipsychotics. We can cause extrapyramidal symptoms, and they can cause akathisia. In the short term, they can cause hyperprolactinemia. They can cause metabolic syndrome, the hyperlipidemia, diabetes. In the long run, they might cause tardive dyskinesia. And we know now also aware of the cardiac side effect of antipsychotics. So the patient needs to know about these side effects to decide whether he accepts the medication or not. Okay, if he's capable to decide to accept the medication. But what's kind of controversial is there is a cognitive and the brain structure effect of antipsychotics that we are using nowadays. So in a study done in 2012, and they were measuring the brain volumes in schizophrenia, and it is a meta-analysis of over 18,000 patients. So they found 317 studies published from September 1998 to January 2012, and over 9,000 patients were selected for meta-analysis, including 33 studies in antipsychotic naive patients. So what the meta-analysis revealed, there is a marked reduced in the brain, total brain volume compared to the antipsychotic naive patients. Okay, so the light gray represent the patient who received the antipsychotics. The dark gray represent the patient who didn't receive the antipsychotics. So the total volume reduced. So there is a reduction in the brain volume whether the patient received antipsychotic or not, schizophrenic patients. But with the antipsychotic, the brain volume loss is greater. And is this only cause of the medication? Or is the patient who didn't receive the antipsychotics were maybe milder, milder severity of the illness, so the brain volume did not cause shrink that much. The greater loss was from the gray matter. So, and we see this both also in antipsychotic naive and medicated patient. The thalamus actually showed a difference, like with the antipsychotic naive, it's actually the loss is greater in the antipsychotic naive, and it's less with the medicated patient. And in the middle, we see that the central cerebral spinal fluid is increased because the shrinkage of the brain, so the space is greater and there is more fluid. Okay. Also in the caudate nucleus, the loss is more greater in the antipsychotic naive patient. So antipsychotic is protective against the loss of the caudate nucleus. So as we saw that both patients who received antipsychotic and patients who didn't receive the antipsychotics have loss in the brain volume. So there is no support that the typical antipsychotics are exclusively responsible for this effect. There is another process going on with this kind of population. So the conclusion was that given there's significant correlation determining whether the larger gray matter volume reduction with increasing the duration of the illness is due to the effect of illness or of the medication, almost impossible to disentangle. So it's difficult to know which one is causing what is causing what. Is it the medication or the illness is causing this reduction? So they recommend another meta-analysis and longer cross-sectional studies to examine the effect of antipsychotic medication. Another study done for the first episode of schizophrenia to kind of catch what happens early in the illness. So they recruited 211 patients with schizophrenia who underwent repeated neuroimaging beginning sooner after the illness onset. So as soon as the illness started, they started imaging them. So on average, the patient had 3 scans. And the follow-up was over up to 7 years. And 14 years and average 7 years. Okay. So the results showed that during longitudinal follow-up, antipsychotic treatment reflected a national prescribing practice in 1999 through 2009. The greater intensity of the antipsychotic treatment, so the higher dosages, the more potent antipsychotic treatment, was associated with a greater brain loss, controlling for the other effect, the other predictors like the illness duration, the illness severity, and the substance abuse. So there is a relationship between the dose of the antipsychotic and not just the illness itself. There is an effect from the antipsychotic use on the brain volume. And this graph showing us the loss in the brain volume, and the left is the red one is the more severe patients, and the right one is the less severe patients that receive less treatment. But in all groups, there is a marked loss in the brain volume. Okay, so that's the end of a chronic patient receiving antipsychotic. So now the argument is it the illness itself versus the medication. So to compare this, we need to compare the effect of antipsychotics on patients who are not, who don't have schizophrenia, to know is it the effect of the illness or is it the effect of the medication. So it's not ethically possible to give patients who don't have psychosis antipsychotic to see if they're going to have brain loss or not. So the other studies we can compare to is the patients who are bipolar illness and receiving antipsychotic medication. So they examined 25 studies examining the effect of antipsychotic agents, mostly atypical this time, on gray matter. And they found there is no significant change in the brain volume except for one study. So this is put us in the controversy. Is that antipsychotics really affect the brain? Or does it only affect the brain of a schizophrenic patient and cause the loss in the brain volume? So next step is to see the effect of antipsychotic on non-human, to examine the effect of antipsychotics. So the usual victim is monkeys. They gave them antipsychotics. And they did it on the macaque monkeys. And they treated for olanzapine or haloperidol for 17 to 27 months. And they measured the plasma level to kind of have a comparable level to a human. And they found there's an 8 to 11% reduction in mean fresh brain weight compared to controls. And it also was evident in postpartum. So this was evident postpartum. So the deficit was present throughout the brain, but was most significant in the frontal and the parietal lobes for some reason. We don't know why. Okay. Another study was contrasting the effect of haloperidol and lithium on rodents, so on mice. And they did a magnetic resonance imaging study with post-mortem confirmation if there's effect in the brain. So yeah, Dr. Tariq is the one who did the study. And this is his MRI. So I was surprised there's an MRI machine for the mice. Yeah. So this is the MRI machine for only designed for mice. Is it the mice or is it rats? I think they're rats. So the effective chronic treatment and subsequent withdrawal of the treatment of antipsychotic haloperidol or lithium caused brain volume changes. So that's the goal of the study. And this was confirmed by MRI and post-mortem studies of the brain. So the mice who received haloperidol showed a marked decrease in the whole brain volume, about 4%, and the cortical gray matter more pronounced loss. And there's a hypertrophy in the corpus striatum. Compared to the mice or rats who received lithium, there's actually increase in the amount of the brain, in the whole brain and the gray matter. So, is this effect on the gray matter a toxic effect of the antipsychotics? So how can we examine this? So we still have time. So we examine the cognition of these patients. So patients who receive antipsychotics, they have loss in the gray matter. Is this beneficial? Is it harmful? So one of the arms of the KT trial, as the way the KT trial is one of the big trials who examined the effect of antipsychotics on schizophrenic patients, was the neurocognitive effect of antipsychotics on the patients. So the primary outcome of this arm was the change in the neurocognitive composite scores after 2 months of treatment. So did they does these scores get down or get better? And the secondary outcomes was to examine their cognition after 6 months and 18 months. And the study showed, this is the result of the study, there's actually improvement in their cognition. Except for the verbal memory and only in the ziprasidone. Hopefully Pfizer are not here. Okay. So there's improvement in the cognition after receiving antipsychotic medication after 2 months. And the overall improvement is also marked with all antipsychotic groups. And there was no difference. So after 2 months of antipsychotic treatment, all groups had a small but significant improvement in neurocognition. And there was no difference between atypical and typical antipsychotics. So the notion that typical antipsychotics cause more neurotoxic effect, this is not supported by this study. Okay. Another study examining the cognitive effect of antipsychotics drugs in first episode. So this is also the new patients who are diagnosed with schizophrenia, form of schizophrenia. This one is an open-label clinical trial. They recruited 498 patients, schizophreniform disorder or first episode schizophrenia, and they were randomized to randomized to antipsychotic treatment, and it was an open trial. So they either tried haloperidol, amisulpride, olanzapine, quetiapine, ziprasidone. Most of the indications are in a kind of therapy, good dosages, except for haloperidol. But as you know, in the West, the dose of haloperidol is lower than they use mostly 5 milligram to 10 milligram. Kuwait, we use, 400 milligram for the patients. Okay. So they did this kind of cognitive testing, the Trail A, the Trail B, the Waze digit symbol, the Bordeaux big board test, and the Ray auditory verbal. And I'd say as the baseline test and the 6-month follow-up showed improvement actually in these scores for all these treatment groups, even in haloperidol group or amisulpride group. And there's no overall differences among the treatment groups between atypical or atypical antipsychotics. And there's a weak correlation between the degree of cognitive improvement and the changes in the PANSS score, meaning that these cognitive improvements are not just because of improvement of their psychosis. It's not just because they are more, there is less hallucinations or less delusions. So there's no correlation between the improvement in their symptoms. There is an improvement in cognition by its, as a separate domain. So I said there's a moderate improvement in the cognitive test performance of patients who have schizophreniform disorder or have their first episode of schizophrenia. So although we know there is the antipsychotics cause reduction in the brain volume, this is not evident in their cognitive testing. So we move to the next step. We examine the effect of medication on the neurogenesis of cells, and this can be done in the lab. This cannot be done in human. So there's lots of studies done this in the lab. So the difference between typical and atypical on the effect of neurogenesis, the effect of on animal. There's also assessment on animal studies, and effect of haloperidol and risperidone, and also paliperidone in neuroblastoma cells. So in the lab, the haloperidol causes neuroapoptosis, so it causes the cell death in the lab. And they attribute this to the free radical induced mechanism, and there is a reduction in the brain-derived neurotrophic factors. Okay? While atypical antipsychotics increase the BDNF and modulate the level of other growth factors. So there's a improvement, and that's in the lab. It's not in the human subject. So they conclude that atypical antipsychotics may afford more protection against apoptosis compared to haloperidol. So going through all these studies, all these experiments, an article published in the Psychiatric Times by Dr. Donald Goff in 2011, he argues that we cannot use this kind of studies to stop giving our patient antipsychotics. First, saying that a longer duration of untreated psychosis has also neurotoxic effect. So we have to balance between the not treating the patient and treating the patient. And also the longer duration of the illness cause more functional impairment and more effect on the brain by itself. Okay. So treating or not treatment also can affect the brain. So the potential for neurotoxicity must be weighed against short-term and long-term clinical gain. So I want to improve the patient, but I'm going to cause some brain loss, or I'm going to keep the patient suffering and prevent this brain loss. So in the meantime, till we find out what's the exact mechanism behind this effect of antipsychotics, the clinician he recommends that should avoid using antipsychotic unnecessarily. So, and for patients who are communicating with insomnia, we shouldn't rush to prescribe antipsychotics. Patients who have maybe other alternative medication, use their more safer medication. And when needed, we use the lowest effective dose, because as we saw with the higher dose of antipsychotics, there is more brain loss. So this can be measured by the side effect and measuring maybe the using scales to measure the improvement and see if we are needing this kind of higher dose of antipsychotic medication. So the questions now we can ask, what's the clinical significance of observed brain volume changes? Is it significant or not? We saw that although there is a brain volume loss, the cognition is not affected. So the antipsychotic may relieve psychosis, but may not arrest or even aggravate the brain loss schizophrenia. So although they are treating the symptoms, but they're not slowing down or not actually maybe worsening the illness course itself. So this is a question, this is not a fact. Okay. The reduction in brain volume may be actually beneficial. Why we are worrying about the loss in the gray matter? This might be that part of the treatment to reduce the gray matter, and that's kind of part of the improvement in the brain. That's what we need to treat. This is how we treat schizophrenia, to reduce the brain volume itself. And the classic maximum we can use here in clinical medicine is to treat the patient, not to treat the laboratory test. So in this case, we don't have to see the MRI. We're treating the symptoms. So we know there's a loss in the brain, but we don't treat the MRI. We treat the patient. Okay. So to conclude, so brain loss in schizophrenia is related to the combination of the neurodevelopmental process of the illness itself, the progression of the illness, and the antipsychotic medication. So there is some brain loss related to the antipsychotic medication. The treatment with antipsychotic medication is associated with improvement in the neurocognition. So we have to put this fact into consideration. But the cell and lab studies shows atypical antipsychotics may have more neuroprotective properties compared to typicals, but this is not showed in the studies which were examined the cognition in the KT trial and other studies. Okay. So reaching the end of this talk, we have, I think, more questions than answers. We still don't know we should use antipsychotic, we should not use antipsychotics. And I open the floor for questions. Okay. So anybody have a question? So we first open it to resident and assistant registrars. Any questions from the back? No. Any questions from the front?
I think, thank you first for this very good, very informative presentation. Actually, as you said, that we are treating a patient, and I think we are not treating the brain volume or So the measure is which is crucial for our treatment is the functioning. When I give a patient an antipsychotic and his functioning improves and his life changed to a better performance and his social, occupational, and even academic, if he's a student, improves. This is an achievement. I'm not looking for the brain volume or these things. This is my opinion.
Mm-hmm. So yeah, I agree with this view. The thing is, if a patient tells you that, if he shows you this study and tells you that the antipsychotic causes brain shrinkage, what are you going to tell him? In the long run, there's a brain shrink. I know my function will improve, but in the long run, my brain will shrink.
And also, you have studies that mention that no correlation between this reduction in the brain volume
and the cognition. Yeah, but we don't know what's the effect of this brain shrinkage. The cognition is intact. There is other. Is it?
I'll tell him that this is not an
Like for example, today we have a patient who was brought by the police. The only symptoms, that's what we know so far, maybe there's other symptoms, that he published a website on the internet against Islam. Nothing, it's just JT. So that's it's only delusions. If he was, I think, in the States and Europe, he will not be brought to the hospital, okay? Because that's only the thing he did. But he's delusional. He has delusion against the Islam. He want to change the values, and he's not against the Islam. It's just he want to change the values in Islam. So in this particular patient, will you prescribe antipsychotic? And he was your patient before. He was your patient before. You saw him before.
We have a criterion in the DSM system that's fixed for almost all illnesses or disorders. If there is an impairment in functioning, whether social, professional, also, I will treat him. Otherwise.
So the thing is, the impairment is function that police brought him to the hospital. So that's a big issue. If he's going to be said that he's not sick, he's going to be jailed because he's publishing data against Islam. The other thing, he divorced his wife because his wife, he said he's not Muslim, so he had to divorce her because his Islam is different from her Islam. So he's.
I will consider this an impairment because of the illness.
Yes, as an impairment, but is it worth prescribing a sorry, I'll get you Dr. Walid. Is it worth prescribing antipsychotic if this patient comes to you, this is if he shows you this article that there's a brain loss because of antipsychotic?
Assessment of his capacity to refuse or accept this is maybe another issue.
Yes. Okay. Okay. So sorry, Dr. Walid, I'll come to Dr. Muhammad.
I think we have to differentiate between two areas, two kinds of patients. Those who present with acute symptoms and who have danger on themselves, on others. In this situation, I think we will have no choice just to treat them because it's not something luxury or something you will look for a long time. But the other kind of patient, those who we will treat for a long time, I think it's their decision. We cannot force them to take medicine. We will give them what is positive, what is negative. Okay, there is any studies suggesting there is shrinkage, but also the psychosis itself, it's by itself can cause brain to be changed during time. So at the end, we explain positive and negatives, and we will tell them what we have, what we do have, and they will choose. We cannot force them. Because I cannot guarantee that after 20 years some other study will come and prove definitely that the psychotic will do damage for them. I will tell them this is what we have, and it's up to you.
So the thing is,
to other or yourself.
So that's the thing, that we get to this kind of point, how to decide if the patient is capable to decide to take medication or not, especially with yesterday's talk with Dr. Walid, that some people patients have the right to be lunatic. So how do you tell them about the capacity? The patient say, no, this is neurotoxic, I'm happy to live with my psychosis, I'm happy to live with my... If there is no aggression, there is nothing, just the psychotic symptoms. If he's only delusional, if he's only hallucinating, then might say some reduction in his social life.
Doing this act will result in a danger to himself and others.
What's the danger?
Because for this.
No, if he's not aggressive. He's just living with his hallucinations, with his delusions, and there is no violence.
What he's doing. What he's doing.
Yes.
I will not describe what he's doing, but what he's doing, he might result in someone who might kill him. In this situation, in this society, in this culture, so maybe in different country, different population, different environment, maybe it's safe, it's okay. But in this culture, this put him in danger. So this is out of.
So that's the thing. Like he's in danger because of his ideas, but is it efficient to get him to treat him because of his ideas that he's in danger of people killing him, but he's not affecting other. Okay, so Mohammed Dardiri and Dr. Mamdouh. Dr. Mohammed Dardiri, you have a question?
Yes, we had cases exactly like you have referred. We had cases brought by family because he is becoming Qur'ani.
He's coming what?
Qur'ani.
What do you mean by Qur'ani?
Means that he doesn't believe anymore in hadith.
Okay.
Okay, and they brought him because they believe that
this is a sickness.
They are literate and they read and they believe that this would fulfill the criteria of lunacy. Okay, and since he is Qur'ani now, so we have to treat him. Okay, I wouldn't treat him. Unfortunately, others did. Okay, we have, but the more repeated example is families bringing their adolescents becoming atheists, families bringing their son becoming atheists, asking to treat him.
And that's the like the DSM defined delusions as the holding beliefs and values against which is not consistent with the society. So like I know if you take this patient to the States, they said he's not delusional, but in Kuwait you might argue this is a delusion.
You can play with the terms of the DSM, saying that.
So is this an illness that requires treatment? And he's a danger. Like this guy can be hanged or killed because he's a murtad. Yes.
So either he's hanged or killed.
Yes.
Both examples might be the same.
So will you treat him or not? I'm not going to say if he's changed his ideas or not, but do you treat him or not, Dr. Mamdouh?
يعني اولا يعني اشكرك جدا في البرزنتيشن لان هي مش بس كان البرزنتيشن هايله والمعلومات كانت هايله والضغط
هحاسبك بعدين دكتور ممدوح هحاسبك بعدين.
ارياز كتيره لها علاقه باور براكتس بالجزء الفلسفي في الريليشن بيننا وبين البيشنتس سواء من الناحيه القانونيه من الناحيه الاثكس من ناحيه حاجات كتيره جدا. ودايما الديبيت ده موجود ولن يحل لا دلوقتي ولا كمان شويه الا لما يكون عندنا قريب شويه من الميديكال موديل. وانا عاوز اربط ده بالمحاضره بتاع امبارح بتاعت وليد فكره السايكوتيك موفمنت اند سو اون، وده كل الديبيت ده موجود وهيتنيه موجود. الى الان لابد ان احنا نشتغل بالتولز المتاحه بالنسبه لنا. وطرق النجاح بالنسبه لنا هو الريسيرش. طول الوقت هيبقى في ريسيرش لما يبقى في تولز جديده تقدر تطلع لنا او تحسب لنا هذا الديبيتس. احنا تقريبا في كل خطوه في كل بوينت في كل معلومه فيها هذا الكونتروفيرسي والديبيت، وده نتيجه لابسنس اوف هايبوثيسيس كامل او كرايتيريا واضحه وزي الميديكال موديل اللي يقدر يغطي جزء كبير من الاسئله. وبالتالي انتل ذس لابد ان احنا يبقى عندنا فيها زي ما بيقولوا جايد لاينز. الجايد لاينز سواء كانت موجوده العالميه او في الايثكس او في كودز او حتى ايفن في الاور براكتس. وي شود تريت ذا بيشنت وين وي هاف اور من التولز سواء من النيزولوجي او من الكالتشرال باوند او من اي ارياز من الانفورميشنز انف ان احنا كونسيستنتلي وي هاف بيشنت اند سواء عنده هارم او نوت. وان بالرولز الموجوده سواء كان في منتال هيلث اكت او عندنا بوليسي بنتابعها بنقدر ناخد كونسنت نعمل دايما مونيتورنج ونراجع دايما الدوزج بتاعتنا وتراي تو افويد الحاجات اللي هي زي الكومباينيشنز والمالتيبلستي او الدوزج العاليه الا في اكسبشنال كيس. لو احنا عندنا هذه الرولز هنقدر ان احنا الى حد ما زي ما بيقولوا نمشي على العكازين اللي نقدر نكمل فيهم براكتس لغايه ما يبقى عندنا زي ما بيقولوا هايبوثيس كامل وخلافه. في ارياس كتيره يعني الامر ده بيرفع على ان عندنا في مشكله اللي هو السب سندرومز نعالج ولا لا. العيانين عندنا تحديات زي العيانين النيجاتيف نديهم وما نديهمش وبنديهم دواء ما بيتاثروش. في عندنا حتى ايفن كرونيك ريزيستنت اللي بتديهم دواء نكمل ولا لا. في اسئله كتيره جدا. فلا نستطيع ان احنا هو جاست ان وي توك. انا يعني يمكن شويه مش موافق دكتور محمد في ان احنا لا لازم ناخد بالنا ان في داتا بتقول ده لكن دايما الداتا تبقى موضوع ابريزل وريسيرش لاعاده اثباتها او عدم اثباتها، لكن اب تو ناو التولز لازم او يعني ما هو متاح من الامور والريسيرش هو اللي يحدد. انا عندي عيان تيبيكالي زي ما حضرتك بتقول اللي هو خد انسايكوتيك هالبريدول فور 5 years due to questionable psychosis حسب كلامه، وخد هذا التريتمنت وجاي بعد فتره كبيره وقفه خلاص وما عادش بياخد، جاي بعد فتره كبيره كله نيجاتيف سيمتومز اللي موجوده، مفيش اكتف سايكوتيك واضحه، وهذا عنده بري اوكيوبيشن واضح. اي دونت نو ما قدرتش ان انا اوصله ان هو ديلوجن بفكره ان الهالبريدول اللي خده عمل له نيورو توكسيستي، وجايب دوكيومنتس كتيره من على النت هذا الدراج هو اللي عمل له نيورو توكسيستي وقلل له الدوبامين وعمل له مشكله في الويل والفوليشن وان سو اون، وبيفسر النيجاتيف سيمتومز او النيجاتيف اتيتيود بتاعه بهذا الامر. وده تشالنج حقيقي ليه في ان انت تو اسيس اذا كان في سايكوز ولا لا، او اذا كان فعلا ده ريال ولا لا، او هاو تو تاكل ذيس بريكيوبيشن العيان، وايه اللي هتديهوله، خاصه انه خد مالتيبل انتي ديبريسنت ومالتيبل دراجز ومفيش تشينج. وبالتالي احنا عندنا حاجات كثيره تشالنجز فعلا سواء في النوزولوجي في وي ستيك تو جايد لاينز تو جنرال رولز الاثكس، ونقدر بالتولز المتاحه من الكلينيكال براكتس والريسيرش جوينج اون عشان يقدر يحسن لنا اور براكتس وذ تايم. This is يعني
I think that's largely the consent of the patient plays into it. يعني احنا في patient who has diabetes and he's not controlled, we don't force insulin on him. He said this is your choice if you want to die or not. Why should we do this? Why should we do this with patients who are psychotic? Why do you have to force medication on them? If they have the right to live with their psychosis, with their hallucinations, if there is no harm to others. But sometimes we do this without the consent. Dr. Mohammed Dartiri.
بس مين
ها ما اعرفش والله.
There is nothing more abusive to a patient, in my opinion, than denying him a treatment that he deserves for a patient of schizophrenia. There is nothing more abusive than this. This is number one. Number two, if we do have a problem with reliability of our diagnoses, so it's a problem of reliability of diagnosis of schizophrenia or other psychiatric illnesses that we cannot. Our diagnoses are not, our tests for diagnosis, our DSM is not sensitive enough or is not specific enough. This is a problem of our diagnostic system, not the problem of it's his right to say no. Okay, because one of the fundamentals of this illness is that he is not aware of his being ill, and he is believing that the aliens or the jinn are haunting him. So yes, it is abusive to let him without treatment.
But who gives you the authority to force medication on him? So they say we don't do this in with diabetes, although we know his diabetes is going to cause kidney injury, going to cause debilitating lifestyle. We don't force that. Why do you have the authority to force medication?
The illness here is in the free will itself. In diabetes, the illness is in islets of Langerhans. Here, the illness is in the concept of free will.
يعني هو دايما احنا وي ار فيزيشنز، احنا عندنا تولز وعندك بتشخص وتعمل انتراكشن مع العيان، في الاخر بتوصل لكونسبت مع العيان. يعني في عيانين دايابيتك نفسهم بيقولوا لا انا مش ما عنديش دايابيتس، انا بالاكل وي اكسبت، بس وي شود ادفايس الفاميلي.
Dr. Mohammed saying that this is not the free will of the patient. We have to treat them despite they are not agreeing with us and they are not.
في لو زي المنتال هيلث اكت او في حتى ايفن قانون بمنع الهارم يو شود انترفين.
Is this harm? Is this harm? Like to live with psychosis?
Yeah.
Is this harm? Is it harmful to live with psychosis?
To live with psychosis? Yes, it is harmful because
there is a potential.
People with drug naive have a shrink brain size, although they are drug naive.
And psychotic will cause more brain shrinkage.
Yeah, but it's already in practice. It has been proven several times.
When it is proven, we can have another tools.
But but it's psychosis by itself necessitate the treatment. If it's not affecting his function, he's living with this kind of ideas that there is jinn or there's aliens, and he's happily.
It's one of the
Psychosis by definition is affecting the behavior performance,
Like
the safety of the patient.
No, it's not really safety. It's not safety. It's just affecting this behavior. But he's living in his house. He has closed the windows. Nobody can look inside his house. But he's living by himself alone.
So the question is if you should treat not psychosis, you should treat
delusional disorder. Do we have to treat delusional disorder?
It depends.
No, I'm not saying no. I'm just debating. I'm just passing this debate.
تعمل تيرورنج according to the patient تحط الرولز اللي عندك وتمشي يعني ما تطلق
so that's the thing like this is
دايما فيها ديبيت.
انا رايي انه في الواقع يعني انه العكس هو اللي بيحصل. يعني دكتور محمد بيقول انه في ناس لا بسبب معتقداتها بيجيبوها. لا انا شايف انه هو كتير قوي بيبقى عندهم معتقدات غريبه وفين لما يقول لك لما يحصل منه behavior معين في oddness او bizarreness هنا بيجيبه. فيعني حكايه ان هم بيجيبوهم علشان معتقداتهم انا بعتقد
بس there is some patients who are brought because of their beliefs.
يعني ممكن يكونوا هم في ناس عندهم زي
في ناس بس في ناس they are brought and now they change in practice they're more with education people are more educated so they recognize these are illness and referring them directly. So do you have time, Dr. We are.
No, yeah, we do have.
Okay, one more question. Okay, 10 minutes. Okay. Before Dr. Costas.
To say that the main thing is that we shouldn't go after eradication of the disorder. So we shouldn't go after eliminating all the symptoms that are there. In that sense, I think this is something in between, and keeping the idea that we have not to do harm. So if the symptoms are there, some symptoms are there, and the person is functioning and he's safe, then we shouldn't go further down with our medication just to make them more well in our sense. So I think this would be something in between.
So that's it.
And doing this is, what's his name, is the quality of life down. Because sometimes people go after the symptoms,
yes,
not the functioning.
So that's the thing, that's the argument that is still going on. Sorry, Dr. Muhammad. Sorry, Dr.
Against the full remission. Totally against full remission.
Okay.
We are targeting.
We shouldn't go for remission. If he's functioning fine.
If he's functioning fine. Like I remember, it's still in my mind. Sorry, this is a story by Dr. Alsayegh and it still sticks in my mind. There's a patient in the UK who was on clozapine, I think a lower dose, like 100 or 200, and he's always coming to he's always mumbling and having hallucination, but he was functioning. So, but Dr. Alsayegh was saying the consultant was refusing to increase the dose of clozapine, despite having this kind of symptom. So once this consultant took a leave and went on a vacation, Dr. Adil increased the clozapine, and he was able to eradicate his hallucinations. A week later, the patient came depressed because the hallucination was the only thing that was keeping him happy. So he was depressed. Sorry, Muhammad.
As we heard yesterday, a priest in a church or a human rights activist might tell us that we have to separate free will from physical illness. But we as psychiatrists, we as biologists are not trying to medicalize the problem, but we don't know anything non-biologic about insight. Lack of insight is a biological problem that, just like diabetes, needs to be treated. And the lack of insight contradicts with the concept of the public concept of free will. This is just another illness that needs to be treated as our obligation, our ethical obligation to our patient.
So who decides this kind of, does this patient have insight or not?
We don't know how to decide. This is our problem.
That's the issue, yeah, that's an issue. Does he have insight or not?
But
Yeah.
it's not
Like if a patient say,
of taking his human right of deciding.
Okay.
Because this means that we are omitting our knowledge that we have a problem in design.
So yeah, for example, the patient we have now, he said, I know my ideas are different about Islam, but lakum dinakum waliya din. I'm not forcing anybody to follow these ideas. So he lacks the insight. He knows that he doesn't know his ideas are wrong, but he's not harming anybody.
I don't believe this is a mental illness.
Because he is diagnosed with schizophrenia and he was being treated for 7 years. And he stopped the medication and the ideas came back. No, because to prove that he's an illness, that when he was treated, these ideas went away. And once he stopped the medication, the ideas came back. But when he's a strong believer that these ideas are right now, and لكم دينكم ولي دين. Sorry, Doctor. Who's okay, Dr. Walid. Okay, تفضل.
I would like just to reply to Dr. Dardiri about the examples he mentioned. You cannot, first of all, we have to go back to the DSM, at least as
Going back to what, sorry?
we have to go back to at least to the DSM.
DSM.
And to make sure that we speak the same language and to fulfill the criteria.
DSM says this is a delusion.
We cannot say that someone who have different beliefs or different belief than this culture, because this culture is not a uniform culture. It's not a one culture. I mean, because this one, the example he said, one he's believe that Quran is alone, and someone he's atheist, or this is all different beliefs. We cannot treat beliefs. The aim of the ground round of the lecture is to treat. If we are sure that the patient is positive for the criteria, we are not questioning the diagnosis.
I'll tell just a real case. One patient was admitted, and maybe you know this patient, admitted to our unit to maybe more than 10 years ago. He assumed a new religion. He invented actually this religion, and he was believing and practicing, and he has made a website for this for more than 5 years. And he was married and he has children. Nobody told him what to, because he was functioning at that time, fairly. Then he started to force his children to pray in a way that a peculiar way. And then when they resisted, and the wife resisted and refused, they started to be aggressive against them. Then they brought him to the hospital.
احتمال هذا البشر عندنا الحين. احتمال هذا هو. لا جاي مرة ثانية لسه داخل. لأنه المرة طلق زوجته لأن she's not following his religion.
Yeah, this is the usual story. Not someone is believing, and here in Kuwait, this happened here in Kuwait, in a conservative culture. So I think nobody will bring a patient because he's not believing in God or he's not believing in Islam, or this is not at least this is not the rule.
Okay.
Exception.
But they do bring girls that they want to have boyfriends.
True.
So what should I say then?
Say this is not accepted.
Bipolar disorder or not?
دكتور محمد آخر سؤال.
I know that the patient is definitely having suffering from schizophrenia, and he tell me no, I don't want medication, and I tell him okay, I don't give you the medication. Then I'm denying, I'm omitting deliberately the notion that I know that he's having a problem in how to decide. Okay, and this is malefacient. This is against our pillars of medicine.
But this is against the will of the patient.
Okay.
Okay. Yeah, I think this argument will go on for a long time. There's no clear answer, yes or no, and that was the reason behind the ground round to kind of raise this question. الفار كيف؟ Any other questions from Andrews and anything?
No, so I just didn't want to comment because I think you're right. There is no right or wrong answer here. I mean, it really depends on the case itself. And I didn't want to put my opinion because I don't want to make anyone becomes biased and saying, oh, the head of the department is with this and with that, so maybe we should do that and that. But honestly, there is no right or wrong answer. Yeah. At least this is my opinion.
Okay, thank you everybody for coming.
Thanks.